Leanne. So I've been given the title Who to Prone. Well, we're all experts right now, aren't we, because of our experiences during COVID, because we proned so many more patients than we thought. But what it's really important to do is that whilst we did this a lot during COVID, it's also important to have a look at the evidence where we are right now and actually to consider whether we need to shift the scale around decision-making around who we should prone. Because certainly in the patients in COVID, we pretty much proned everybody. And what I hope to do in the next sort of 15 minutes is actually look at some of the current evidence around proning and maybe challenge some of our pre-existing notions around this. So we all know about the benefits of proning. It optimises your VQ mismatch, it increases your FRC, it assists with secretion drainage, and the altered chest wall mechanics certainly improves hypoxia, and it also ensures a uniform distribution of plateau pressure. But these are some of the relative contraindications that we all know very well. Facial injury, that's very clear. That's not going to be in the patient's best interest. But it does depend on the degree of the facial injury and whether the balance of managing the hypoxemia and the implications for the facial injury and which is the most critical at that particular point. Neurological issues, that's very obvious. We don't want patients prone seizing. Morbid obesity, I put a little star by that, and we'll talk about that a little bit later on. But I think certainly we proned patients on the morbid obese scale more in COVID, when pre-COVID we probably wouldn't have considered doing so. And some of that is around staff becoming very, very familiar with the process. And so that gave us increasing confidence to probably prone patients that maybe previously to the COVID pandemic we probably wouldn't have. It's obvious that the second to third trimester of pregnancy wouldn't be ideal for proning for obvious reasons. And pressure ulcers, we're all very well aware of the implications of those. In terms of adverse events of proning, pressure injuries, we certainly saw a great deal of these in the large cohorts of patients that we'd proned. Pressure injuries across the nose, the forehead, the genitalia, the knees, and certainly areas that we wouldn't expect normally. Hemodynamic instability, I'm going to come back to, because I think that's always been an adverse event and one that maybe has altered the decision about who we are going to prone. Accidental extubation, again, is something that we're always concerned about when we prone patients. But again, we've got highly skilled teams of people now who are very confident with the proning process, and that does take away some of the anxiety. It may breed just a little bit of complacency too, so we always need to be aware of that as an implication and a potential adverse effect of proning somebody. Ocular injury is always been described as an adverse event for proning, and absolutely yes, if we don't manage padding the eyes appropriately before we prone patients, there is a significant risk of ocular damage. But actually the evidence is that patients who are supine are far more likely to suffer ocular damage than those who are prone. And that's probably because in all of our checklists around proning, careful attention to managing pressure on the eyes and covering their eyes appropriately makes us consider this maybe more than we do for the patients who are supine. So NG feeding, in the early days, we didn't feed people when they were prone because there was concerns that this was going to cause regurgitation that they wouldn't absorb. I think we've all moved on from that, and we still feed patients now when they're prone and use the usual assessment about whether they're actually absorbing or not. So in terms of prone positioning, we know there's lots of evidence out there. We know that it doesn't do significant benefit or harm, and I think that's the important thing. It's become a bit of a trendy thing to do because we've done it so much in recent times. but it may confer a benefit in terms of mortality, and that's really important to consider. But if you look at all the studies around long-term mortality data, so that's 12 months and beyond, we also need to consider the functional, neuropsychological and quality of life data, bringing into what the impact of being prone has had on this patient group. So this is the Perceiver trial, which many of you will have heard of, which by Guérin in 2013. That's one of the seminal papers, and certainly many of the papers that have been published since show Perceiver as a clear outlier. Because this did show that 90-day mortality was significantly improved by proning. And this is certainly a paper that we still refer to now, even though it's 10 years old. I draw your attention to these guidelines. So these are the ESICM guidelines on ARDS, and these have been updated in the last couple of years, and very much worth a read, because I think we all hold some beliefs about ARDS, and actually what this does do is challenge some of the evidence and possibly some of our practices. So who are we going to prone? So the evidence for proning patients in ARDS is very strong. The recommendation is very clear. And we know that ARDS accounts for about 10% of admissions to ICUs in general, and 23% of our ventilated patients. But we also know that the mortality for these patients, if they're ventilated in the ICU with ARDS, is around 45% in the severe category. What we've learned, and what you will see in the ESICM guidelines, is that we all know about the Berlin criteria of the way we categorise whether somebody's got ARDS or not. But what we see is patients with acute hypoxic respiratory failure, secondary to either a bacterial or viral pneumonia, or in cases of septic shock, actually fall into the same category and probably should be considered for proning. So prone positioning in COVID-19, we found out fairly early on in the early waves that actually, when delivered early, proffered a very significant effect on oxygenation in about 80% of coronavirus disease. And remember, in the intensive care world nationally, we've never had a huge cohort of patients with one pathology for whom that we can actually study the interventions that we've made and whether they make a difference or not. And I think what we're going to see in the coming years is lots and lots of data, because that case mix is massive. And for intensive care patients, that's significant. But we will probably see lots more evidence coming out from this period. But we also know that those people who responded to being proned, and we usually knew fairly early on when we proned a patient with COVID whether they were going to be a responder or not, but those who responded were independently associated with an improved survival. So other patients who we should maybe consider proning. There's been some discussion around whether you can prone patients on ECMO, and that not too long ago would have filled most of us with a degree of anxiety, given the equipment required for that. But actually, what we found is that proning during ECMO actually improved oxygenation and was actually associated with a reduction in hospital mortality. Now, some of this may be in relation to the fact that now we've got staff who feel this is part of their core skill set. And so that means that they're far less likely to have issues with line misplacement and adverse events during the actual procedure of proning somebody. But if you're on VV ECMO, you've got a higher probability of surviving if you're proned and being weaned off ECMO at 90 days. So what they found is that it increased the oxygenation ratio. But however, the increase was not sustained once the patient was returned supine. So what it may do is provide a bridge to weaning somebody from ECMO. So patients who are having ECMO, they're certainly not excluded from being proned. Post-extubation. So there is evidence, and there are studies out there that say that post-extubation it is feasible to prone your patient and that it's safe. My big question there is why? So why would you extubate your patient when you've got a definitive airway and then put them prone? It's just my personal and clinical opinion that maybe your selection criteria for extubation may be needing to be looked at rather than thinking, OK, I'll extubate you and then I'm going to put you prone. But that's just my personal view. But there is some study to say that proning it was a small sample study, but they said that if you could extubate patients and then you could put them prone, that was a safe alternative. I would say that probably we need to consider very carefully which patients we should be extubating and taking it from there. So there's been some discussion around whether patients can be prone if they've got a traumatic brain injury. And obviously there are significant concerns there around raised intracranial pressure. But there have been some studies into this which suggest that patients who have concurrent ARDS and an acute brain injury without significant raises in ICP, that actually there's some low evidence in favour of consideration of whether actually improving the oxygenation may actually improve the neuroprotection of the brain in that situation. But there's no evidence out there around whether proning patients with significant ICP is safe or not, for very obvious reasons. So, proning an acute brain injury, we have to consider the intracranial pressure, and so that's something that, if you're even considering that, that's something that should be being monitored. So in a neurointensive care unit, they found, whilst on initial turning, that there was a significant elevation in intracranial pressure during prone positioning. The oxygenation that was improved by proning outweighed the risks to ICP. But that is something that you would need to be continually monitoring in this patient group. So you would be really talking about neurosurgical centres. We've all got increased experience of proning in obesity. Technically it is possible. Yes, it's challenging, but technically we can. But in thinking about who to prone, we need to think carefully about what the implications of proning these patients are, because just because we can doesn't mean we should. Because what we found in the evidence, that abdominally obese patients developed renal failure in 83% over those who'd been left supine. That's significant because that's another organ failure in addition to their respiratory failure and any other organ failure they may also have. Also, because of the pressure generated by being prone, that there was a much higher incidence of hypoxic hepatitis. Again, we're potentially adding in a complication of another organ failure into whatever has brought them into ICU initially. So there's a significant interaction effect between abdominal obesity and prone positioning with an increased mortality risk. Again, we need to be assessing patients individually and balancing the risks as to what's most appropriate for that individual patient and whatever their pathology is. So, yes, we can prone abdominally obese patients, but actually we should consider a very cautious approach and also keep a very close eye on renal and liver function to make sure that we're not actually making the situation wholly worse. So I said I'd come back to hemodynamic instability because it's one of the things that we always say, well, we can't prone the patient because they've got arrhythmias, they're on high doses of vasopressors, and that might cause a significant issue just in the very action of proning. But the Perceiver study showed that there were fewer cardiac arrests, and we can do CPR effectively in the prone position. We've discovered that and had lots of experience of that in recent years. So prone CPR is something that is feasible. But what has been found is that 72% of patients in this group, they received a similar dose of vasopressors to those patients who were supine. Okay, so that wasn't that. There may have been a transient increase just on the positioning, but actually they didn't have significantly higher doses of vasopressors. So again, it's a balance between managing the oxygenation and managing the sequelae of actually turning the patient prone. But what was quite interesting is that in a series of severe ARDS patients, that prolonged pronings of about 18 hours led to normalisation of the right ventricle in half of the patients who'd shown significant right ventricular systolic dysfunction at the start. So there may be an element there of a bridge to things improving. Proning with a tracheostomy. So yes, we can prone patients with a tracheostomy. It's technically slightly more difficult in terms of the way you manage how the patient is supported around the neck area so that there isn't additional pressure damage. It's also much more risky in terms of if the tracheostomy becomes dislodged, it's less straightforward to recognise if the patient is prone. Unusual rules apply here around having consideration, is this the right thing for this patient, but also having the right protocols and equipment handy should the patient tracheostomy become dislodged. But there is no reason in the evidence or practically why a patient with tracheostomy cannot be proned. So awake prone positioning is something that has become something that we're seeing a little bit more frequently, and obviously since COVID. And I'm making no apologies for talking about COVID, because we've had great opportunity to get experience during what's been a very difficult time for critical care. What we found is that those patients with COVID-19, that actually if you could encourage them to be prone themselves for periods early in the disease course, that there was some benefit in improvements in oxygenation, and particularly with high-flow nasal oxygen and, in some cases, with NIV, generally well tolerated. However, if you go back to the ESICM guidelines, awake-prone positioning did reduce the requirement or the need for intubation. However, you need to be monitoring very carefully the comfort and the need for intubation. What it shouldn't do is delay intubation in a patient for whom they should be being intubated. So actually the evidence is that there's a weak recommendation for proning patients in non-intubated patients with COVID-19, and the experts were unable to make a recommendation for or against in non-intubated patients in relation to mortality. And so, again, that's not saying that's not a modality that we shouldn't use. It's saying that actually we need to assess the individual patient and see what is most appropriate for them. There's also evidence that suggests that multiple episodes of awake-prone positioning didn't actually lead to sustained benefits for oxygenation, and the size of the response and benefit for patients may not improve after the first couple of episodes. Does it delay endotracheal intubation? Potentially, and we need to be aware of that. And it may be useful for those patients for whom it wouldn't be appropriate to intubate. So it may be an appropriate strategy for those patients for whom the ceiling of management is that. Okay. So who not to prone? Those in significant distress, those with an imminent need for intubation, those with an agitated or conscious mental state. Proning is cost-effective, and it may protect against some of the high-tech and very expensive manoeuvres that we undertake. So in summary, we need to weigh up the benefits and risks to individual patients about whether proning is appropriate or not. Most importantly, it's important to know who not to prone. An individualised assessment is always key. Any questions?
Thank you.
Thank you, Carole. That was great and certainly picked up a huge amount of our experience as well as the evidence that's around. Do we have any questions? We've got 1 minute. We can take a question. I'll get you to come down to the front here just quickly. Otherwise, we'll never hear you.
Hello. Hi, Carole. Wonderful talk there. It was just with regards to when you're saying about optimising oxygenation, especially with neuroprotective measures. Is that then something that should be considered with more patients who are coming in generally that need neuroprotection for their optimisation, and potentially even patients who could go for organ donation to make it the most optimum treatment?
Thanks for the question, Georgie. I think reviewing all the evidence around proning, I think the issue is it has to be considered on an individual case-by-case basis. And I think that's the important thing that's come out of the evidence so far. I think as a bridge to organ donation is challenging because inevitably needing that amount, that degree of hypoxia would probably preclude certainly heart and lung transplant, but may not preclude kidneys and other organs. But as I say, when you look at obese patients, and there may be an implication on renal perfusion and so on by being prone. So I think it's about assessing individual patients and actually balancing whether that improvement in oxygenation is going to benefit them as an individual. But it is about weighing the benefits and risks.